Thank you. I'd like to start off by saying that female reproduction and producing offspring is serious business. And the reproductive system is really fine-tuned not only to the internal milieu, but also to external circumstances. And I'm going to review some of that with you today, with particular emphasis, of course, on drug-induced amenorrhea. That's fine. Perfect. Okay. Just a very quick review of the hypothalamic pituitary ovarian axis. As you know, GnRH is produced by the hypothalamus, brings about the release of the two gonadotropins LH and FSH. These stimulate the ovary not only to produce hormones, but also to develop the mature, ripe Graafian follicle, which is ovulated, as I'll show you on the next slide. And the two important hormones, estradiol and progesterone, are produced in the ovary. And there's both a negative feedback as well as a positive feedback, thank you, of the hormones on the hypothalamic pituitary axis. And briefly, the fairly complex ovarian cycle starts off with essentially selection of a dominant follicle out of a group of follicles that are in the growing process. The most advantaged is selected to be dominant, and in response to LH, androgens are produced. These are aromatized under FSH influence to estradiol, which is the dominant hormone of the follicular phase of the cycle, and commensurate with this hormonal production in response mainly to FSH, the follicle grows into a ripe, mature Graafian follicle. By that time, estradiol has peaked, and that peak has been maintained for a certain length of time, and there's a positive feedback effect on the anterior pituitary, bringing about the gonadotropin mid-cycle surge, which allows for rupture of the follicle, release of the oocyte, hopefully into the fallopian tube, and the cells that remain behind form the corpus luteum. And under the influence of LH, of course, the corpus luteum produces progesterone, and meanwhile, at the level of the endometrium, in the first half of the cycle, you have the proliferative endometrium in response to estrogen. In the second half, you have the secretory endometrium, which is in response to progesterone, preparing the uterus for implantation. The corpus luteum only has a limited lifespan, and in a non-pregnant female, it only hangs around for about 2 weeks. After that, it becomes less and less responsive to LH. It undergoes luteolysis, and the endometrium is no longer supported, and the woman has her menses. And this goes on time after time after time, unless it's interrupted by pregnancy or by illness. And of course, this is something you're all very familiar with, but I want to spend a minute on this slide. Gonadotropin-releasing hormone, of course, is responsible for the two gonadotropins, FSH and LH. Then there's growth hormone-releasing hormone, somatostatin, TRH, which is predominantly involved in TSH production, corticotropin-releasing hormone, which gives rise to ACTH, and prolactin, as is well known, is under negative influence through the inhibitory effect of dopamine. Just 2 points. Corticotropin-releasing hormone, ACTH, and glucocorticoids play an enormous role in the reproductive system. When you're under tremendous stress, you don't need to reproduce. And GnRH shuts off, which is why women develop what we call functional hypothalamic amenorrhea. The same thing if you're starving, you don't need to reproduce. Hence, in anorexia, that system shuts down. If you have a state of energy deficit, as in the marathon runners or the people who are excessively exercising, that system will shut down because GnRH is highly sensitive to the external, or rather to the internal milieu as well as to the external environment. And all of that is very critical for female reproduction. The other thing I'd like to point out, of course, is we all know that prolactin in excess shuts off GnRH. Effectively, this is nature's method of birth control. For the first 6 months, if you're exclusively breastfeeding, you don't have any periods, and especially with suckling, the prolactin rises, and GnRH is shut off. After that, usually there is recovery of the hypothalamic pituitary ovarian axis. With that, how do medications affect the hypothalamic pituitary axis? It can do so in one of three ways. One is to suppress GnRH itself or influence its action. The second, of course, is to induce hyperprolactinemia, leading to GnRH suppression. And the third is to create an inflammation of the pituitary. So one of the drugs that's already been talked about that suppresses GnRH directly is are the opioids. These affect men and women equally, or perhaps a bit more so even in men. We see it more in men, leading to hypogonadism. It's often under-recognized and a relevant history is needed. You have no idea how many times I've picked up an opioid-induced functional hypothalamic amenorrhea, effectively, but induced by a drug, just by asking the right question. And if I'm not sure what the amenorrhea is due to, I always ask that question. And opioids may also transiently, after the dose, increase prolactin, as Dr. Nader-Eftekhari also mentioned to you in the talk yesterday. And this is a slide from my former dean, Dr. Ernest Nobile, who really put GnRH pulsatility and GnRH function on the map, so to speak. He took ovariectomized rhesus monkeys for this type of experiment, and he implanted electrodes in the mediobasal hypothalamus, which is where the GnRH pulse generator is housed, and he recorded the electrical activity. And commensurate with each pulse of electrical activity, there was a pulse of LH. And then he gave the rhesus monkey a 2-minute infusion of morphine. And you can see the effect of that. For about 4 hours, the system completely shuts down. This is how powerful opiates are on this system. And then by the time the effect of the morphine has worn off, then the system recovers again. The next drug I'd like to talk about briefly, and we don't think of them as drugs that inhibit reproduction, but in fact it is, the long-acting GnRH agonist. GnRH itself has a very short half-life, and the pharmaceutical industry became interested in this many, many years ago, about 30, 40 years ago, and they wanted to develop drugs that would have long-acting GnRH action. And GnRH itself is a decapeptide, fairly simple molecule, and they changed some of the amino acids like leucine, tryptoline, and histidine, and they brought about different compounds that had agonistic action. And these GnRH agonists, such as leuprolide, with which we're all familiar with, they were developed as agonists, and they do act as agonists. But unfortunately, they only act as agonists for about 5 to 12 days, increasing LH and FSH in the process. And after that, there's downregulation of GnRH receptors. This follows because the reason for that is that appropriately paced pulsatile GnRH is needed for receptor action. And for a while, they were not in disuse. It wasn't a useful drug for the purpose for which it was developed, until we realized that we could really shut off the reproductive system for good reason for other circumstances, such as for the treatment of central precocious puberty, for endometriosis, in assisted reproduction to inhibit the LH surge so that we remove the influence of LH just when we are trying to get a ripe, mature follicle. And of course, in men, they're used for androgen deprivation therapy for prostate cancer. And again, I'd like to show this experiment from Dr. Nobil's work. And here, what he did, he actually destroyed the mediobasal hypothalamus, getting rid of the GnRH pulse generator. And then he gave the rhesus monkey GnRH 1 pulse per hour, which is close to the physiologic frequency. And you can see that with that, you have appropriate LH and FSH production in the ovariectomized monkey. And then when he changed the pulsatility to 3 pulses per hour, it completely shuts down the system, because you need that appropriate pulsatility to maintain the cellular LH pools, and doing it too rapidly shuts it down. And then when he restores it back to 1 pulse per hour, it all comes back to normal. As I've mentioned, the adrenal axis plays a big role in GnRH, and there's a crosstalk between the hypothalamic pituitary adrenal axis and the ovarian axis, and this crosstalk promotes amenorrhea as a functional adaptation to stress. For example, corticotropin-releasing hormone decreases GnRH. This has been shown in women. Infused CRH decreases gonadotropins, and this can be prevented by GnRH. And CRH also decreases GnRH in rhesus monkeys. Glucocorticoids themselves suppress gonadotropins in rhesus monkeys, prevented by GnRH. And in women, prednisolone in supraphysiologic doses also decrease the LH response to GnRH, a pituitary effect. So not only does CRH act in the system, but the very glucocorticoids themselves can negatively impact reproduction. And again, from the same experiment with the electrodes implanted in the rhesus monkey with pulses of electrical activity, pulses of LH, when CRH, corticotropin releasing factor, is administered, of course, cortisol goes up, but look what happens to GnRH and LH, it just plummets. So the next major group of medications that can affect reproduction are, of course, drugs that induce hyperprolactinemia. And these are drugs that are usually dopamine antagonists. And they've been talked about throughout this conference. The first generation antipsychotics have a moderate to high effect, and also, in addition to that, the D2 receptor gene variants may influence their effects. And these drugs include chlorpromazine, haloperidol, flufenazine. The second generation antipsychotics have a much lower effect, such as olanzapine, or no effect, as in quetiapine. And the exception to this second generation group is risperidone, where the prolactin may be very high, up to 200 micrograms per liter range, very high, with a normal of about 25, 30. And paliperidone can also do that. And of course, as is already known, antiemetics such as metoclopramide can have pretty high effect, and also domperidone, which we don't use in the United States, but we certainly use metoclopramide. In addition, methyl-dopa has a moderate effect on increasing prolactin. It decreases dopamine synthesis. I've seen this on several occasions in obese, hypertensive women who are trying to get pregnant. They're told they can't take ACE inhibitors or ARBs, so they take methyl-dopa, and they have a high prolactin. Verapamil, a calcium channel blocker, has a moderate effect, possibly related to calcium influx inhibition. I have not actually seen a case of that, but I've certainly seen several of methyl-dopa. And even H2 receptor antagonists such as cimetidine and other antidepressants can do that, but they have a much lower effect. SSRIs generally have no effect or a very small effect. And of course, estrogen in high doses itself, depending on how much you use, can have a prolactin elevating effect, just like occurs in a pregnancy. I'd like to sort of switch gears and start off by presenting this case. This is a patient I saw in 1990. It was the first case I had ever seen, and I was sort of shocked by it. We even published the case. It was a 22-year-old patient who was seen for secondary amenorrhea and galactorrhea. Her menarche occurred a little late at 17, followed by monthly cycles. She was pregnant at 21 with delivery 9 months before the visit to me. She did not breastfeed, but she continued to produce milk and had no further menses whatsoever. She lost about 13 kilos after her delivery. Interestingly, 3 months before I saw her, she had gone to the emergency room and was seen there and hospitalized briefly. She was seen for nausea and vomiting, fever, feeling weak. She was rehydrated with saline, and during that time she was found to have a serum glucose which was 48 micrograms per dl, or 2.7 millimoles per liter, a fairly low glucose. She was not on any medications, and on examination she was a thin, sick-looking female with bilateral expressible galactorrhea. Her prolactin was 60, the normal less than 25 for that particular lab. Her LH was on the low side, 1.9. Her FSH, mid-normal range. Her cortisol was unmeasurable. Her free thyroxine index was a little low, and her TSH was an acceptable range. An MRI showed an enlarged optic chiasm, a thickened pituitary stalk, which was retracted into a partially empty cella. Her visual fields and acuity were normal. This was the first case of lymphocytic hypophysitis that I have seen, and it originally it was thought to be mainly a postpartum disease or in late third trimester, where they can present with headaches and a pituitary mass. The hallmark, the radiologic hallmark, at least for those that relate outside the new agents, which we're going to talk about, is actually stalk thickening. If you see stalk thickening, that should be part of your differential diagnosis, as in this particular case. The first case ever reported was reported by Gowdy and Pinkerton in 1962. They described a young woman, pretty much exactly her age, who had delivered a baby about 18 months before that. She had the misfortune to develop, and she never had a period after that delivery. She had a misfortune to have acute appendicitis, was taken to the operating room, and she died. And they did an autopsy, and they found lymphocytes in the anterior pituitary and the thyroid. And they had the foresight to suggest that this may be an autoimmune disease affecting both the thyroid and the anterior pituitary. Of the first 8 cases reported, 6 were autopsy diagnoses because the diagnosis was missed. And of course, we don't want to go and unnecessarily do pituitary biopsies on people either. So you just have to be very aware of this possibility. And of course, now fast forward almost 30 years, and now we're talking about drugs that affect the immune system, which we've heard about a lot during this conference, particularly CTLA-4, cytotoxic T lymphocytes antigen and 4, and also the PD-1, which is programmed cell death 1, and the ligand PD-L1. These drugs are now used for melanoma, for lung cancer, and many other cancers in which they are being tested. And as you already know, the immune system, and to go back to the pregnant patient, pregnancy is a state of immune tolerance. After you deliver, the immune system goes wacky. It goes into a little bit of overdrive, which is why women get postpartum thyroiditis and much less commonly lymphocytic hypophysitis. And in the normal physiology, there's a checkpoint, there's a balance, there's a break, control over the overreactivity of the immune system. And what these drugs do is they unleash the immune system to attack everything it can possibly attack, mainly the tumor, hopefully, but they also, of course, attack the normal tissue. And so immune checkpoint blockade, these anti-CTLA-4 drugs act in the proximal step of the immune system, and the anti-PD-1 or the ligand act at a later stage of the immune system. And these inflammatory side effects can affect the endocrine system, GI, skin, liver, etc., as I will show you on the next slide. Hypophysitis and colitis are particularly seen with the anti-CTLA-4 antibodies, and in a recent ACE abstract in the United States, nearly 13% of ipilimumab-treated melanoma patients developed hypophysitis. And here's a diagram from a very up-to-date review published in the New England Journal of Medicine. It was published in January of this year, and as you can see, multiple organ systems are affected. Uveitis, dry mouth, vitiligo, myocarditis, type 1 diabetes, of course, thyroiditis, hypophysitis, colitis, and central nervous system effects, and so on. They are really pervasive in their actions. And what the authors stated is that the mechanisms underlying, or the possible mechanisms underlying adverse effects include enhancement of T lymphocyte activity, increasing the production of antibodies against tumors and as well as normal tissue, increasing pre-existing antibodies, the production, unleashing the immune system to produce more antibodies when they're already present, the production of inflammatory cytokines that may, again, affect the tumor. And I'm going to enlarge this last one, which is relevant to hypophysitis, enhancing complement-mediated inflammation due to direct binding of anti-CTLA-4 antibody with CTLA expressed on normal tissue. And as it happens, CTLA is expressed on anterior pituitary cells, which is perhaps we see the lymphocytic hypophysitis. And this is what the article also said, which I found interesting. This usually occurs in the first few weeks or months of therapy, but can occur at any time. Why it affects some people and not others is unknown, possibly genetic, and they mentioned host microbiota. It's unclear if the occurrence increases the efficacy of response. People have talked both ways. We don't know, and some people think that if you have this kind of response, maybe your tumor will respond better too. But according to the article, it's really unclear. And then they said that treatment with immune suppressants such as glucocorticoids does not appear to reduce the anti-tumor efficacy of the actual drug. And restarting may not always be necessary if the tumor has already responded. But you can restart depending on the severity of the side effects or switch to an anti-PD-1. And they also said that patients with pre-existing autoimmune disease may still benefit from this blockade. Next topic, we're going to move down to the ovary. This is one of my favorite diagrams. A woman is endowed with a certain number of germ cells and effectively has no mechanisms for renewal. The peak germ cell mass is reached at 20 weeks of intrauterine life, and thereafter, by a process of atresia, apoptosis, the germ cell content of the ovary is essentially depleted by the time she gets to menopause. We don't talk about hormonal activity in a 6-year-old because the hypothalamic pituitary axis that controls the ovary is quiescent. It wakes up at puberty and remains active until old age. So between menarche and menopause, we talk about the reproductive years where all systems are go, and the ovary should be producing follicles and mature Graafian follicles. So the primordial follicles, which exist in the ovary, over months develop into pre-antral follicles, and then over time they become early antral follicles, and then medium-sized antral follicles, and finally become the ripe, mature Graafian follicle with which we are all familiar. And these oocytes are surrounded by granulosa cells that produce the hormones, and theca cells, of course, that produce androgens. The granulosa produce the estradiol. And this is the ripe, mature Graafian follicle, but there's a big, long growth process to get to that point. Now, the medications that affect the ovary as far as loss of germ cells are of course, or effect on ovarian function directly, are the chemotherapeutic agents. And most anti-cancer drugs affect the dividing cells, the granulosa and the theca that are proliferating and active during folliculogenesis. And hence the observation that many women less than the age of 40 develop amenorrhea during chemotherapy with high LH and FSH, but menstrual function returns months and sometimes even months later. And the effect of the drug on oocytes and the primordial follicles is variable and is agent dependent. And of course, it is age dependent because the older you are, the less oocytes you have anyway. So the dose of the drug depleting oocytes varies with the age of the woman. For example, 5 grams of cyclophosphamide in a woman just over 40 may give her permanent amenorrhea versus 10 grams or even 20 grams in much younger women. Alkylating agents are the most damaging, affecting both the resting cells, the oocytes, as well as the dividing cells, and it is believed that what they actually do is they alter base pairs leading to DNA cross-links. And the alkylating and other agents have been, the chemotherapeutic agents have been divided into groups that definitely, probably, or unlikely have an effect on ovary. Of course, we know that cyclophosphamide, chlorambucil, melphalan, procarbazine, busulfan, dacarbazine, these are the ones that quite definitely affect the ovary. Probably the vinca alkaloids, some antimetabolites, heavy metals, tyrosine kinase inhibitors, as listed in this group. And of low probability are antimetabolites such as methotrexate and vinca alkaloids such as vincristine as opposed to vinblastine. So there is a differential effect. And people have looked at different regimens for different diseases. For example, in MOP for Hodgkin's, you can get permanent ovarian failure in anywhere from 12 to 46%. Biocop also for certain lymphomas may cause amenorrhea in about 50%. Some of the newer regimen are more variable with lower toxicity. But regardless, they will have some effect. And in a report of 2,819 childhood cancer survivors who were over age 18 8% had ovarian failure, as opposed to 0.8% of the siblings. So there is a difference. And as you would anticipate, if you've lost germ cells, you're going to, even if you've recovered, you are going to have an earlier menopause than you would have had without that chemotherapy. That's kind of a given. And last area, the outflow tract. We don't talk about the outflow tract much as endocrine doctors, but it does play a role. You need a uterus for pregnancy. Now, we often use progestin compounds for contraception. And the most popular these days are the levonorgestrel IUDs that release progesterone directly into the uterus, and progesterone implants. These are norgestrel implants that are placed in the arm. But of course, our much older one is Depo-Provera, medroxyprogesterone acetate, which is given every 3 months, and for that duration, it inhibits pregnancy. All of them may decrease ovulation at hypothalamic pituitary level. They inhibit the LH surge, big dose progesterone. Although some follicular growth may continue to occur, they suppress estrogen-mediated endometrial maturation. So many of these women, even though they may make some estrogen, they are often amenorrheic for the duration of the treatment. However, what's different between levonorgestrel and etonorgestrel implants and IUDs from Depo medroxyprogesterone acetate is that the Depo may take months for recovery. So you give an injection today, it lasts for 3 months, but it may take another 6 months or so for recovery. And in 25%, they may have to wait for a year for resumption of menses after the last injection. And this is infuriating to a lot of women. They stop the Depo-Provera hoping they're going to get pregnant next month. That doesn't happen, and they have to wait, and they wait, and they wait, and they are anxious. They don't know what is going on with them. I've seen this many times, and I just want to illustrate this with a quick case, and then we'll finish. This is a 44-year-old woman who had had prior regular cycles, 2 pregnancies, who was evaluated for amenorrhea. She was also pre-diabetic and weighed 88 kilograms. And in fact, I heard a distinguished speaker many years ago say that he thinks that the reason for the Depo-Provera effect is that Depo-Provera hangs around in the adipose tissue. And that's why the more overweight. And the cases that I've seen, to my recollection, were almost all overweight. So she weighed 88 kilograms. Her last Depo, she took Depo-Provera from 2015, and the last injection was January 2017. She had no menses off Depo-Provera, and I saw her in late 2017. I told her this is Depo-Provera effect, very likely, and I did some labs. Her FSH was intact, consistent with her age. Her LH was lower, not 0, but it was lower. She had a normal prolactin, and her prior TSH had been normal. I told her to come back in a few months. I told her she's going to recover. Come back again in a few months, and I'll see her. Well, she didn't come back in a few months. She came to see me in August, 8 months later. And she still had no menses. She was upset, and she said, "But you told me I was going to get my periods back." And I said, "Yes, I did. I'm sorry." And of course, the telltale sign is she was now complaining of some hot flashes, night sweats for a few months. And by this time, and I checked this last month, her FSH was 54, LH 37, normal prolactin, and TSH. So it took her over a year to recover from the Depo-Provera effect, and she went from one kind of amenorrhea to another kind of amenorrhea. And so we do see this from time to time, and it's just one should perhaps warn patients of that. So how do we investigate these patients? Of course, LH, FSH, estradiol, prolactin, ACTH, cortisol, thyroid function for possible hypothalamic pituitary drug-induced effect, and pituitary MRI possibly for suspected hypophysitis if you aren't sure of the diagnosis. And remember, anything that affects the pituitary hypothalamus is going to affect LH more than FSH. FSH is age dependent, and it has its own set of control factors, whereas LH is highly influenced by the pulsatility of GnRH. So that's something worth remembering. In the case of the ovary, FSH, LH, estradiol, anti-Müllerian hormone, which will be low, antral follicle count for possible ovarian failure related to chemotherapy. And of course, if you're going to measure FSH, don't do it at any time of the cycle because FSH is cycle dependent. So AMH, you can actually do it in pretty much any time of the cycle. But for FSH, the highest level of FSH is in early cycle. So a day 3 FSH is what is our standard. I tell a woman, if day 3 is a Saturday, do it on Friday. If day 3 is a Sunday, do it on Monday. You want it tight. Otherwise, doing it on day 9 or 10 is not going to give you much information. But AMH will do that. And of course, in the case of Depo-Provera, LH is likely to be suppressed, as in the case I showed you, it was lower than the FSH. FSH will be intact. Estradiol, not that helpful, but it may be low. And pelvic ultrasound may show a thinning of the lining because you lose the stimulatory effect of any estrogen. Thank you very much. I hope I didn't...